Hi friends, in this video I will talk about T wave. First is the disclaimer. Caring Talks YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention and treatment of medical illnesses. There is no endorsement for any brand or a company. T wave is the positive deflection after each QRS complex. It represents the ventricular repolarisation. Normally, T wave is upright in all leads except AVR and V1. Amplitude less than 5 mm in limb leads and less than 10 mm in precordial leads. This is the normal amplitude, and duration relates to the QT interval. T wave abnormalities. These are peaked T wave, hyperacute T wave, inverted T wave, biphasic T wave, camel hump T waves, and flattened T waves. This is the ECG, shows peaked T wave, this tall, narrow, symmetrical peaked T waves. These are seen in hyperkalaemia. Hyperacute T waves. These are broad, asymmetrical, peaked, or hyperacute. These are seen in early stages of ST elevation MI. Often they precedes the appearance of ST elevation and the Q waves. Particular attention should be paid to their size in relation to preceding QRS complexes, as hyperacute T wave may appear normal in size if the preceding QRS complexes of the small amplitude. They are also seen in prismatic angina. Loss of precordial T wave abnormalities occur when the upright T wave is larger than that in V6. This is a type of hyperacute T wave. The normal T wave in V1 is inverted, and upright T wave in V1 is considered abnormal, especially if it is tall and especially if it is new. This finding may indicate a high likelihood of coronary artery disease, and when new implies acute ischemia. Inverted T waves, they are seen in normal in children, persistent juvenile T wave pattern, myocardial ischemia in infarction, including Wallens syndrome, bundle branch block, ventricular hypertrophy, pulmonary embolism, hypertrophic cardiomyopathy, raised intracranial pressure. T wave inversion in lead 3 is a normal variant. T wave inversion compared to the prior ECG is always abnormal. Pathological T wave inversion is usually symmetrical and deep, more than 3 mm. We can remember inverted T waves as incorrect lead placement, bundle branch blocks, ventricular hypertrophy, embolism, reciprocal or refractory MI, sudden death, iatrogenic due to digoxin, obtended because of increased intracranial pressure, and it could be normal variant. Here, this is a pediatric T wave. Here we can see inverted T wave in the right precordial leads, that is V1 to V3, and these are normal finding in children, and they represent the dominance of the right ventricular forces. Persistent juvenile T wave pattern. Here we can see T wave inversion in the right precordial leads, which may persist into adulthood and are also commonly seen in young Afro-Caribbean women. Persistent juvenile T waves, they are also asymmetrical, shallow, and usually limited to V1 to V3. Myocardial ischemia and infarction. Here we can see T wave inversion due to myocardial ischemia or infarction in contiguous leads based on the anatomical location of the area of ischemia or infarction. For example, inferior leads are lead 2, 3 AVF, lateral leads are lead 1 AVL, V5, V2, V6, anterior leads are V2 to V6. Note, dynamic T wave inversions are seen in acute myocardial ischemia. Fixed T wave inversions are seen in following the infarction, usually in association with pathological Q waves. Inferior T wave inversions are due to acute ischemia. Here we can see inferior T wave inversion with Q wave, suggesting prior myocardial infarction. In this ECG on the left, we can see anterior T wave inversion with Q waves due to recent IMI, and on the right side, we can see T wave inversion in the lateral leads due to acute ischemia. Here, in bundle branch blocks, T wave inversion is an expected finding even in the absence of ischemia. Appropriate discordance refers to the fact that abnormal depolarization, such as bundle branch block, should be followed by abnormal repolarization, which appears discordant in the preceding QRS complexes in the form of ST deflection and T wave inversion. On the left side, we can see left bundle branch block. On the right side, we can see right bundle branch block. This produces T wave inversion in the right precordial lead, that is V1 to V3. Here, ventricular hypertrophy, both left and right ventricular hypertrophy may produce T wave inversions. For example, left ventricular hypertrophy, it produces T wave inversion in the lateral leads, that is lead 1 AVL V5 to V6, with a strain pattern with a similar morphology to that of left ventral branch block. Right ventricular hypertrophy produces T wave inversion in the right precordial leads, that is V1 to V3, and also the inferior leads, that is lead 2, 3 AVF. In pulmonary embolism, we can see acute right heart strain, that is secondary to massive pulmonary embolism. It produces similar pattern to RVH, and we can see T wave inversion in the right precordial, that is V1 to V3, and the inferior leads that are 2, 3 and AVF. Here in this ECG, this is suggestive of acute massive pulmonary embolism. Here we can see S1, S wave in the lead 1, Q wave in the lead 3, T wave in the lead 3, that is S1, Q3, T3, with right bundle branch block with T wave inversion in V1 to V3, S wave in lead 1, Q wave in the lead 3, and T wave inversion in the lead 3. This ECG is of hypertrophic cardiomyopathy. It is here we can see deep T wave inversion in all the precordial leads. Here we can see widespread deep T wave inversion with bizarre morphology. It is because of increased intracranial pressure as seen in subarachnoid hemorrhage. Coming to the biphasic T waves, there are two main causes of biphasic T waves: myocardial ischemia and hypokalaemia. Here, the two waves, they go in opposite direction. Biphasic T wave due to ischemia Here the T wave goes up then down, and biphasic T wave, due to hypokalaemia, the T wave goes down then up. Wellen syndrome is a pattern of inverted or biphasic T waves in V2 to V3. For example, in patient presenting with or following the ischemic chest pain that is highly specific for critical stenosis of the left anterior descending artery, there are two patterns of T wave abnormalities in Wellen syndrome. Type A is biphasic T waves with initial deflection positive and the terminal deflection negative, seen in 25% of the cases. And type B is T wave, they are deeply and symmetrically inverted and seen in 75% of the cases. The first ECG represents the type A, and second on the right side represents the Wellens type B. Camel Hump T waves is the term used by Amal Mattu to describe T wave that have a double peak. There are two causes of the Camel Hump T waves. Prominent U wave fused to the end of T wave as seen in severe hypokalaemia, and hidden P waves embedded in the T wave as seen in sinus tachycardia and various types of heart block. Here we can see on the right side top prominent U waves due to severe hypokalemia. Hidden P waves are with the sinus tachycardia is seen in middle part of the ECG on the right side, and hidden P waves with marked first degree heart block at the bottom of the right ECG. Hidden P wave in with the second degree heart block is also seen in the left side of the ECG, left sided ECG. Flattened T waves, they are non-specific finding but may represent ischemia if dynamic or in contiguous leads or electrolyte abnormality like hypokalemia. Dynamic T wave flattening due to anterior ischemia is seen in the above ECG, and then the T wave returns to normal once the ischemia resolves, as seen in below ECG. In hypokalemia, we see global T wave flattening associated with prominent U waves in the anterior leads, that is V2 to V3. Nature, time, and patience, they are the three great physicians. It is according to Bulgarian proverb. With this, I conclude my today's topic. Thank you. Keep learning.